So I think we can start. Good morning, good afternoon, good evening, everyone, depending on which time zone you are at. Welcome to this webinar, which is entitled Update to the WHO Tuberculosis Screening Guidelines, What People Living with HIV, Implementers, and National Program Managers Need to Know. My name is Timur Abdullayev. I'm an outgoing Stop TB Partnership board member and also a board member of TBpeople, the global network affected by TB. And I'm going to be your MC or DJ for today's webinar. We have a packed agenda, so unfortunately I won't be able to take any requests to play your favorite songs. Sorry. Our aim for this webinar is to provide an opportunity to discuss these guidelines and their implications for people living with HIV, implementing partners and governments. Presentations will highlight how to implement these new guidelines in the current context of health system constraints and challenges due to the COVID-19 pandemic. So thank you all for joining us today. This webinar is endorsed by TBpeople, the International Union Against TB and Lung Disease, also known as the Union, the Aurum Institute, and the Treatment Action Group. First of all, let me introduce you to Lena Golub, the Senior Project Manager, HIV Programs and Advocacy at the International AIDS Society, who will be providing some guidance on housekeeping rules before we start today's webinar. Please, Lena.
Thank you, Timur. So just a couple of housekeeping rules before we start. Please note that due to the number of attendees, all participants are currently muted. So feel free to send your questions during the presentations because we will have some time at the end to answer those. Please put them in the Q&A box. You will notice that there's a thumbs up symbol where someone will ask a question in the Q&A box. If you have a similar question or find this question important, please click on this thumbs up sign, and this will really help us prioritize the questions because we only have limited time for those. And then in case you're having any issues with Zoom, you can find additional guidance provided in the chat box on how to use Zoom. And please also send any technical questions to the team that will be addressed there. We have planned time after the presentations for the Q&A, as I've already mentioned. So please send your questions there, focusing on today's topic. If your question is for a specific speaker, please indicate their name when typing your question. So now we would like to thank our donors, the Swiss Agency for Development and Cooperation, Merck Sharp and Dohme, and Gilead Sciences, without which this webinar would not be possible. Thank you, Timur. Now please go ahead for the start of the webinar.
Thank you, Lena. This part is so different from what we used to have in face-to-face meetings, where housekeeping meant things like where the toilets are or use your phones. But anyway, let's move to the real start of today's webinar. We have 5 great speakers today. Cecily Miller, Technical Officer of the Global TB Program of World Health Organization in Switzerland. Grania Brigden, Director of Department of Tuberculosis and HIV in the International Union Against Tuberculosis and Lung Disease in Switzerland. David Branigan, TB Project Officer of Treatment Action Group in United States. Patrick Celillungu, National TB and Leprosy Program Manager, Ministry of Health in Zambia. And Salome Charamboulos, Deputy Chief Scientific Officer, Associate Professor in the Aurum Institute in South Africa. So with this, I would like to invite our first speaker, Cecily Miller. Dr. Cecily Miller is a technical officer with the Global TB Program at the WHO in the TB Prevention, Diagnosis, Treatment, Care, and Innovation team. She's an infectious disease epidemiologist by training, and her area of focus is TB screening and active case finding interventions, as well as implementation research for innovations in TB care. She has been with the WHO Global TB Program since 2019, and prior to that, she worked for 10 years with the TB Center at the University of California, San Francisco. presenting on what's new in the updated WHO TB screening guidelines and what does this mean in context of HIV. Dr. Miller.
Hello, and thank you for having me present at the session today. My name is Cecily Miller with the Global TB Program at WHO. And today I'll be presenting on systematic screening for TB disease, the updated WHO recommendations and operational guidance, specifically for screening of people living with HIV. So I'll just begin by defining what we mean by systematic screening for TB disease. And that is the systematic identification of people at risk for TB disease in a predetermined target group by assessing symptoms and using tests, examinations, or other procedures that can be applied rapidly. So here we are distinguishing it a bit from standard clinical care. And some key features of it are that it should be done systematically, of course, in a selected or target population. So not just done by provider suspicion. It should be done using a highly sensitive tool to distinguish people that have a higher probability of TB from those with a lower probability in which TB can be effectively ruled out. It should be followed by a diagnostic evaluation using a test with a high accuracy to confirm a diagnosis prior to initiating treatment. And it needs to follow established ethical principles specific to screening that, again, are a bit distinct from standard clinical care. So why is screening for TB so important among people living with HIV? Well, we know that there's still a large burden of TB disease and mortality due to TB among people living with HIV. People with HIV are more vulnerable to TB and to rapidly progressing from infection to disease and then to mortality. And we know, of course, that TB is still a primary cause of death among people living with HIV. And we also know that there's still a large TB case detection gap among people living with HIV. So an estimated 44% of people with HIV who had TB were not diagnosed or started on care in 2019. Early detection and treatment are really essential if we're going to reduce this excess mortality, and screening is essential to improving early detection. Screening for TB, lastly, is also an essential first step prior to initiating TB preventive treatment, or TPT, or for other really essential care packages, including the package of care for people living with advanced HIV disease. So for these reasons, routine screening for TB among people living with HIV has been recommended by the WHO since 2011, so for a decade now. It was further codified in the first set of screening recommendations that the WHO released in 2013, which you can see up there on the upper right in green. And the past several years have brought some advancements and new evidence to this field. So last year, the WHO commissioned a guideline development group to update these guidelines, to bring them in line with the most recent evidence, including evaluating evidence for new tools and new technologies for screening that have come to light, and to provide more specific implementation guidance on screening, including screening algorithms for distinct subpopulations to be screened. And screening of people living with HIV was a particular focus for the update of this guideline. So for this, the WHO commissioned a systematic review and independent patient data analysis, or IPD, that looked at the performance of a variety of different tools for screening people living with HIV. So these new guidelines, released in the form of these consolidated guidelines and operational handbook, which you see there on the right in orange, were released this year in time of World TB Day. And you can get them here at the website, or you can use these QR codes to access the documents directly. Now, the resulting updated recommendations included 17 recommendations in two different parts. First were recommendations for populations to be screened. And second were recommendations for tools to be used to screen those populations. So I'll briefly go over the first part of what populations are recommended to be screened for TB, so you can see how screening for HIV, people living with HIV, fits into that picture. And then I'll go directly into the tools that are recommended for screening people living with HIV. So firstly, there are 4 populations in which screening for TB is strongly recommended. This includes household and close contacts of people with TB. It includes people living with HIV, it includes minors exposed to silica dust, and prisoners. And so for these populations, screening should always be conducted. And the question is how. what tools and algorithms should be used, what implementation model makes the most sense in a given setting, what frequency makes the most sense. TPT should be provided when it's appropriate. We know that this is strongly recommended both for people living with HIV and contacts of people with TB. And of course, monitoring and evaluation should be conducted to assess the outcomes of a screening program and to revisit and revise the implementation model if necessary. In addition, there are several populations in which screening is conditionally recommended. So this includes people with risk factors for TB who are seeking healthcare or in healthcare in settings with a 0.1% prevalence or higher. So we consider this moderate prevalence settings of 100 per 100,000 or higher. So some risk factors here include malnourishment, diabetes, chronic lung disease, a history of previous TB, and there are several others that can be considered. This recommendation is essentially getting at the fact that it can be very efficient and targeted to screen people for TB who are already in the healthcare setting, but perhaps are seeking care for another reason. It can also help with infection control and triaging. People with untreated fibrotic lesions seen on chest X-ray should be targeted for screening because they are at an increased risk of developing TB in the future. In addition, screening should be considered in populations with what we call structural risk factors for TB. So factors of their built environment that increase their risk for TB and are often associated also with limited access to healthcare. So here we're talking about urban poor communities, homeless populations, refugees, migrants, and any other vulnerable or marginalized groups in which there's an increased risk or prevalence of TB and a limited access to healthcare. And finally, screening should also be considered in the general population, now in settings with a TB prevalence of 0.5% or higher. So this is the equivalent of 500 per 100,000 or higher. So in these populations, screening consideration should be given prior to initiating screening. That includes weighing the benefits and the risks of screening, considering the opportunity costs that come with screening for other TB interventions or any other health interventions. As we know, screening is a resource-intensive activity. And prioritizing those risk groups that really represent the greatest burden or have really the greatest vulnerability in a given setting. So now I'll go directly to the tools that are recommended for screening people living with HIV. And we start here with the WHO recommended 4-symptom screen. And this includes screening for any one of cough, fever, night sweats, or weight loss, wherein any one of these symptoms would be considered a positive or abnormal screen, and the person should be evaluated fully for TB. This screening tool has been recommended since 2011 for screening people living with HIV at every healthcare visit. And it remains the most feasible screening test, most easy to implement. However, we have seen over the past few years, data has shown that it has sometimes limited accuracy in some subgroups of people living with HIV or in some implementation settings, which can sometimes hamper its implementation. So for instance, here on the right, we see that it has suboptimal specificity across all people living with HIV, which means that a higher portion of people who don't have TB will screen positive and therefore be referred for diagnostic evaluation unnecessarily, which also slows down the time at which they can be initiated on TB preventive treatment or provided other care. We also see that the sensitivity among outpatients who are enrolled in ART and in regular care is suboptimal. Here we see the estimate of 53% sensitivity, meaning that almost half of prevalent TB cases in this population are not being picked up by this routine symptom screening. So for this reason, the group looked at other possible screening tools, the first of which is C-reactive protein or CRP. And the analysis looked at its accuracy as a screening test and actually found that it was a very accurate screening test for TB among people living with HIV. So it is now recommended. CRP is a general marker for inflammation, and it can be performed as a point of care test using a finger prick lead spot, as you can see in the picture illustration there. And the IPD analysis found that it has similar sensitivity and similar or improved specificity to the 4-symptom screen across all subgroups of people living with HIV. And that sensitivity or specificity, of course, can be targeted depending on what cutoff is used. And the group looked at a cutoff of 5 and 10 milligrams per liter, as you can see on the table on the right. Now, in particular, this tool was found to represent a significant improvement in accuracy, particularly in specificity, over symptom screening, specifically for people who are living with HIV who are not yet on ART, not enrolled in regular care. So this tool means that a lot more people who don't have TB will correctly screen negative and can go directly on to TPT initiation or other care. The group also looked at the performance of chest X-ray as a screening tool, and not surprisingly found that it improves sensitivity of screening, particularly when conducted alongside symptom screening for all populations of people living with HIV. In particular, this tool represents an improvement in sensitivity for those patients who are on ART and are enrolled in regular care. And this is the group that we saw earlier was sometimes being missed by purely symptom screening. We see the addition of chest X-ray to that screening increases the sensitivity to 85%, which is much improved. We don't have enough data to specifically recommend the frequency of which this tool could be used for screening. But some data from the WIP3 trial suggests that annual screening with chest X-ray and symptoms picks up a lot of additional cases that pure symptom screening would miss. And this is also a feasible to implement frequency. Now, the group also looked at a new development in the past several years, which is computer-aided detection software for automated interpretation of chest X-ray. And based on the data that showed it has similar accuracy to human interpretation, the use of CAD software is now recommended as a possible alternative to human interpretation of chest X-ray for TB screening and triage. And this is in all adults aged 15 years and older, and this is including people living with HIV. Now, unfortunately, we can't yet recommend this for children because the software are not yet developed to work in children, but we see that this is also a rapidly developing, advancing field. So hopefully we see developments in this line for children in the near future. And I just want to draw your attention on the bottom to 2 further resources for this. First is the landscape of CAD software. Our colleagues at FIND and the Stop TB Partnership have put together some resources here that show the current available technologies for CAD. And they are numerous. And again, this is a rapidly advancing field. So you can see here what different options are on the market and what their requirements and specifications are. Also at the bottom here, this CAD for TB detection website contains some implementation guidance and tools to help with new implementation of CAD in a setting. One of the things that emerged from the evaluation of the data was that CAD, the accuracy and the sensitivity and specificity in particular of a given threshold of CAD can vary quite a bit depending on the setting in which it's used and the population in which it's used. So we see that calibration is really required when implementing CAD in a new setting. Lastly, the group looked at the performance of molecular WHO recommended rapid diagnostic tests. Now, the acronym is MWRDs. This includes expert, TrueNat, or other tests in the same class. And these are now recommended also as potential screening tools for people living with HIV. And the group specifically gave a strong recommendation for using this in a screen and treat strategy for medical inpatients or hospitalized inpatients, people living with HIV in high burden settings, which we're defining here as medical wards with a TB prevalence of 10% or higher. And in this situation, because of the severity of illness in this population and the need for rapid action, the group recommended that you proceed with a screen and treat strategy, and no further diagnostic testing is needed when there's a positive test. That can be enough for, it can be a decision to treat, essentially. It's also conditionally recommended for all other people living with HIV, with the caveat that due consideration needs to be given to make sure there's adequate access to these tests for diagnosis prior to scaling them up for screening. Now, lastly, for children living with HIV, as all the previous tools had been for ages 10 years and older, except for CAD, which is specific to 15 years and older, Children living with HIV, screening is also recommended in this group. In fact, children with HIV are one of 2 groups of children in which screening is recommended, the other being child contacts of TB patients. Unfortunately, we just don't have the data yet to recommend some of these other tools for screening in children, but symptom screening, including screening for cough, fever, weight loss, and or any contact with a TB patient or a person with TB is strongly recommended. Now, lastly, I'll show briefly some different screening algorithms that have been developed and are presented in the operational guidance that goes along with these recommendations. I won't go through them in too much detail, just to show that and to explain that now we have a menu of options that can be used for screening people with HIV. These algorithms show how some of these tools can be used alone or in combination to flow from the point of screening to diagnostic evaluation or referral for TPT. So here we see some single screening test algorithms, symptom screening on the left, CRP in the middle, and chest X-ray on the right, where these tests flowed to diagnostic evaluation on the bottom left here, or TPT evaluation if the screening test is negative or normal. Here we have some single screening algorithms for MWRDs, including on the left, the screen and treat strategy we described for inpatient people living with HIV. We also have some examples of parallel or serial screening algorithms whereby 2 screening tools are put together. On the left, we see a parallel screening strategy where 2 screening tools are used at the same time, and a positive result or an abnormal result on either one of the screening tests results in a referral for diagnostic evaluation, whereby or a negative or normal result on both of them results in ruling out TB, and the person can be referred for TPT. Now, this strategy tends to have higher sensitivity than a single screening test, but it has lower specificity. So oftentimes more people are referred for diagnostic evaluation, perhaps unnecessarily, and it can have higher resource implications. In the middle here, we have a serial screening algorithm whereby 1 screening test is performed, and if a person has an abnormal or negative or positive screening test, they go on to another screening test prior to diagnostic evaluation. Now, this can enhance the efficiency of a screening algorithm and essentially reduce the number of people who go on to diagnostic evaluation, but it does have lower sensitivity. And on the right, we have what we call a serial negative screening algorithm, whereby people are screened by 1 tool, and if they screen negative or normal on that, they go on to 1 additional screening tool before eventually going to diagnostic evaluation or having TB ruled out and being referred for TPT or other care. Now, this has the same sensitivity and specificity as a parallel screening algorithm, but it has lower cost implications because the more expensive screening test is only done on those who are not screened positive by the initial test. And here we have similar options with chest X-ray, and I won't go too much into those. Here's an option, here's a screening algorithm for symptom screening among children. So with that, I want to acknowledge the other staff at WHO, especially Annabelle Badley, who really led the development of the HIV screening guidelines. Saskia Den Boon led the development of the operational guide. Dennis Falzon oversaw this whole process, and all the other WHO staff. Evidence reviewers, especially Gary Martins and Ashar Dana at the University of Cape Town, who performed the IPD analysis that informed these recommendations, and all the other groups and contributors and patients who contributed data to this. So thank you very much.
Thank you very much, Dr. Miller. It's really great to see that in addition to good old symptom screening and chest X-ray, we now have newer tools like CRP coming, and I'm really looking forward to having these tools rolled out really fast. I think we need some paradigm shift in terms of screening, and it looks like we have a lot of hope, even though the COVID pandemic brought us some challenges, which is also reflected actually in one of the questions on our questions and answers board, but we also hope. Now let me invite our next speaker. Now our next speaker is Grania Brigden. She is the director of the Department of TB at the International Union Against TB and Lung Disease. In this role, she is involved in developing and expanding the union's global programs for TB, HIV, and other comorbidities. She oversees projects working on all areas of TB, from drug-resistant TB to child and adolescent TB. She was involved in the development and launch of TB Science. She's a member of a number of scientific committees and was made a fellow of the Royal College of Physicians of Edinburgh in 2019. She will be presenting on where to from here, comment on the guidelines and recommendations from an implementer perspective. Grania, please, the floor is yours.
Thank you very much for asking me to give some thoughts today regarding the implementer's perspective with the new WHO screening guidelines. So, hello, I'm Dr. Grania Brigden. I'm from the International Union Against TB and Lung Disease. So, what I've been asked to talk about is the sort of implementer's perspective of where to from here. So, really sort of breaking this down into the opportunities that these new screening guidelines give us, particularly for people living with HIV, as well as some of the challenges. So I think, first of all, it's very welcome that these guidelines have been updated from the 2013 guidelines, particularly given the number of new tools and increasing evidence that has been shown regarding the use of these new tools, and to reiterate the importance that we must be screening everyone living with HIV, children, adolescents and adults, for TB at all available opportunities as well, and not just to diagnose TB, but also to support the TB preventative activities as well, and help reach the UN high-level meeting targets on TPT for people living with HIV. So these new guidelines from an implementer's perspective really give us an opportunity to reinvigorate the screening work. And I think this is particularly the case with the COVID-19 situation, where screening may have fallen down the priority list as countries have been working on dealing with their first, and in some cases second and third waves of the COVID pandemic. But with new guidelines really gives us an opportunity to reinvigorate screening, incorporate it into any catch-up campaigns to ensure that we are identifying those who are at risk with TB and either would benefit from treatment or TPT. I think the inclusion of a number of existing tools, but allowing them to be used for, or recommending that they're used for screening, and new tools also helps address maybe some of the concerns that might be around kind of just using a symptom screen. And so the potential to use WHO recommended diagnostic tests, as well as CAD technology, so computer-aided diagnosis technologies for chest x-rays, will all help reassure healthcare workers and implementers around the confidence of their screening. Some of the challenges, there's been quite a lot of new updates and new tools, I think particularly with regards to people living with HIV and screening for TB, is the inclusion of CRP, and just sort of thinking about how to implement this in real life, given that CRP is a potentially sort of a very broad tool. It's not sensitive or specific just to TB. It is picking up inflammation sort of from other causes. And so I think there's probably a need for more operational research into how we can successfully incorporate CRP into our screening for people living with HIV, and sort of how best we can use that in programmatic settings. I think the other challenge is that these guidelines came out after a lot of countries had put in their next submission for Global Fund. So the budgeting for potentially more of these diagnostic, what are sort of perceived to be diagnostic tools rather than screening tools, would not have made it into those grants. So it may take a while for repurposing any sort of Global Fund grant or other donor grants to reflect the new guidelines, because they do have a budget implication to sort of incorporate WHO recommended rapid diagnostic tests, molecular tests, or procuring digital chest X-ray with CAD technologies and software embedded into it. Then there's also, particularly with screening activities for people living with HIV, is sort of where these activities occur within both the TB program and the HIV program, and how to sort of who's procuring the various new tests that have been highlighted in these guidelines, and just making sure that this is planned for, and that there's the collaboration and coordination between the national aid programs and the national TB programs when it comes to screening. And then I think the other, as I said at the beginning, sort of real key point is how can we really use these screening guidelines to not only identify our missing cases, to not only catch up with the cases that we've missed in the last 12 to 18 months due to the COVID-19 situation, but really also, particularly for people living with HIV, is how do we reinvigorate or reinforce the need for test, treat, prevent. So kind of looking for TB, identifying those who have TB disease and rapidly starting them on the correct treatment, as well as identifying those who don't have TB disease but either haven't received TB preventative treatment or are at risk or have been exposed to TB disease, and making sure that they are also rapidly put onto TB preventative treatment, with a real, I think, focus on some of the more shorter regimens that kind of help promote adherence and make it a more person-centered approach to care. So these are some of the initial reflections from a sort of implementer's perspective. Very happy to talk and answer any questions about this more. And I'd like to thank my colleagues for feeding in their reflections. Thank you very much.
Thank you very much, Grania. Indeed, thank you for bringing up both the opportunities and the challenges. And some of them are really like they resonate. You know, the eternal question: who is doing the TB screening, diagnosis, and treatment, and TPT among people living with HIV? Is it the AIDS program, or is it the TB program? So, and the question, which I don't think it's been answered once and for good yet. So it's really interesting to see and reflect on those points that you brought in your presentation. Thank you again, Grania. Now let me go to our third speaker, David Branigan, project officer at Treatment Action Group, where he leads advocacy to promote TB diagnostics, research, and access. David closely follows scientific developments relevant to TB diagnostics, create resources to sensitize activists, policymakers, and other stakeholders to these developments, and advances advocacy campaigns to promote equitable access to TB diagnostic testing at the highest standard of care. He served as a member of 3 WHO guideline development groups, including the GDG on TB screening, in 2019 after working as a researcher and journalist on issues of intellectual property global health policy, and economic and social rights. He holds a Master of Science in International Affairs from the New School. So David will be on where to from here, comment on the guidelines and recommendations from civil society. So David, the floor is yours, please.
Greetings, everyone. My name is David Branigan, and I'm the TB Project Officer at Treatment Action Group. I'm very happy to present to you today on the updated WHO TB screening guidelines from a civil society perspective. The updated WHO TB screening guidelines, recommendations, and algorithms are a welcome development offering guidance and new tools to improve systematic screening for TB in general, and specifically among people living with HIV. The new guidelines build upon the existing strong recommendation that people living with HIV should be systematically screened for TB disease at each visit to a health facility, which according to 2021 PEPFAR country operational plans is a generally accepted approach to care. The new guidance, however, offers new tools and algorithms that country programs can adopt and implement to improve TB screening, diagnosis, and linkage to treatment for people living with HIV. These tools include computer-aided detection, which can be used in combination with new portable digital chest X-ray devices, C-reactive protein, which is a relatively sensitive and specific screening tool that can be implemented as part of routine care, and the new indication to use rapid molecular tests such as GeneXpert and TrueNat for TB screening among people living with HIV. It is very exciting to see these developments in the guidance. There is a gap in the guidance, however, for the use of these screening tools among children living with HIV, and the only screening tool that is explicitly recommended for children living with HIV is the WHO 4-symptom screen. Existing TB screening and diagnostic technologies are not as sensitive in children and often require invasive sampling approaches, making chest X-ray a critical tool for diagnosing TB in children. There is a pressing need to train computer-aided detection algorithms on child X-rays to fill current gaps in data and update the guidance with recommendations on the use of TB screening among children living with HIV. Now that these recommendations have been made, key challenges of access to the recommended tools must be addressed. Access to quality TB screening and diagnosis is a human right. Country governments are obligated under the right to health and the right to science to provide access to TB screening, diagnosis, and treatment at the highest standard of care in line with WHO recommendations. Just because a WHO recommendation is made does not mean that it will be implemented. For example, LF-LAM testing was recommended since 2015, yet in 2019, only 13 out of 30 high TB HIV burden countries had a national policy for the routine use of LF-LAM testing. Community-led monitoring is a powerful mechanism that can be used to identify gaps in care to improve quality of TB services, and should be implemented in every country as an integral component of the health system to build TB screening and diagnostic literacy in communities and mobilize communities to create demand and engage in advocacy for the implementation of new tools and algorithms. There needs to be more investment in community and civil society-led initiatives. For governments to meet their obligations to uphold the right to health and science, country programs must scale up new tools, which, to be used at scale, must be made affordable. To make the best use of computer-aided detection for systematic screening, this software can be paired with new portable digital chest X-ray devices, which are currently quite expensive, ranging from $15,000 to $50,000. Achieving lower prices will require competition as well as active negotiation with companies for fair pricing based on the cost of production and volumes. We should continue to direct our efforts toward realizing lower prices and scaling up access to point-of-care and community-level chest X-ray. WHO recommended rapid molecular tests, including GeneXpert and TrueNat, continue to be priced above what is feasible for countries to be able to scale up rapid molecular testing as the initial TB test for all. GeneXpert TB tests currently cost about $10 per test, and TrueNat TB tests cost $9 per test, which are not evidence-based prices. An evidence-based price would be based on the cost of production plus a reasonable profit with volume-based price reductions. What will it take to achieve lower prices for rapid molecular tests? I ask this because the strong recommendation to use rapid molecular tests for TB screening among people living with HIV in inpatient settings and the conditional recommendation to use these TB screening tests among all people living with HIV are groundbreaking. To what extent will price be the limiting factor? Finally, I would like to note that improving TB screening and diagnosis among people living with HIV will require increased investments. The updated TB screening principles state that TB screening should always be done with the intention to follow up with appropriate medical care. If a community lacks access to appropriate follow-up care but would benefit from TB screening, this should be an impetus for investment by national TB programs in TB diagnosis and treatment services in order to complement TB screening. We need to close gaps in access to TB screening, diagnosis, and treatment, which has been made even more urgent in the context of COVID-19. Closing these gaps is an active process that requires investment and accountability to the public in the form of including affected communities and civil society at the decision-making table, from product and policy development through implementation, and in the form of affordable access and fair pricing of TB screening and diagnostic tools so that countries can afford to scale them up and implement them according to WHO recommendations. Thank you.
Thank you very much, David. Yep. More of a challenge to scale up than price. I've seen how much it matters the period, and even though it was a revolution in diagnosis, it took so much time to actually push for it to be introduced. Very relevant considerations, and as an activist myself, I can only say that yes, we need more reasonable prices, I would say, for screening and diagnostics, diagnostic tools, including CRP, including gene expert, including everything else. Thank you, David. And let me go to our next speaker. Our next speaker is Patrick Celillungu. Dr. Patrick Celillungu currently works for the Ministry of Health as National Tuberculosis and Leprosy Control Manager and consultant in internal medicine. He's a holder of master's degree in medicine in internal medicine, Bachelor of Humanology, and Bachelor of Surgery and Medicine. He is the co-chair of the National TPT Search Committee. He's also a researcher on TB. On TB HIV programs, lessons learned, and steps towards adopting and implementing the updated WHO TB strategy. Dr. Patrick Lungu, the floor is yours, please.
Hello, everyone. I'm Patrick Lungu, the National TB and Leprosy Program Manager for Zambia. So I'm delighted to share with you the impact of COVID-19 with regard to TB HIV interventions in Zambia. This is my outline of my presentation. I'll move forward to actually share the background in which TB and HIV is in Zambia. So Zambia is one of the 30 high TB burden countries in the world. And I'd like to say that before the year 2020, Zambia was missing about 38 to 40% of the estimated burden. 2020 was a very active year, and it was in the same year that Zambia recorded the first cases of COVID-19. And it is one of the years in which we had actually planned to scale up our intervention for finding the missing TB patients. And this, we intended to do it through a collaborative approach. So the outbreak of COVID-19 posed a very huge threat on our aspirations. Similarly, as well, in 2019, Zambia embarked on a roadmap to scale up TB preventive therapy. So all our plans that we had were under threat, not only for TB cases finding, but also for TB preventive therapy. So I'd like just to say that through a collaborative approach, Zambia was able to sustain the TB HIV intervention, of which I will share the details in the slides to come. So this is one of our landmark achievements, just to highlight to everyone that 2020, despite the COVID-19 outbreak, Zambia recorded the best performance ever with regards to finding the TB patients. So how did we do it? And also just to share with you that it was in the first quarter when Zambia recorded the first cases of COVID-19, just pre the World TB Day. And as you could see from this slide, the cases were increasing. The cases of TB that were being found were increasing towards the World TB Day. And around week 12, Zambia recorded the first cases of COVID, and the measures to respond to COVID started, which resulted in the decline in cases of TB that were being detected. because we noted OPD attendance stopped and also community interventions were withheld. So that in itself resulted into a 22% decline in weekly TB notifications, and this was over a period of 4 to 8 weeks. We were lucky to notice this quickly because we had already established a weekly surveillance system. So through that, we were able to pick up the decline. And we were concerned about the decline because all our aspirations were going to be lost. So essentially what we did was we did consult all our key stakeholders and we established what we are calling the TB Situation Room. And this TB Situation Room is a virtual platform on Zoom where we connect with all levels of healthcare, starting from facilities, district, provinces, and up to the national levels, including all our key partners from both HIV as well as our TB partners. Through the efforts and mitigating some of the emerging issues, we started to see that our efforts were yielding results. And this is what we recorded. By the time the year ended, we were able to restore the TB services. And by end of 2020, we recorded a 10% increase in TB notification when we compare to the past years. And this is the reason that we achieved the best performance amidst COVID. So in itself, in as much as COVID brought a lot of challenges, it also presented an opportunity for us to be sitting on a weekly basis at all levels, responding and looking at data to the emerging issue. This slide, colleagues, shows us how we performed in the year 2020 in the first 21 weeks. And this is how we are performing in 2021 in the first 21 weeks. So just to say that the strength and the systems that we built in Q2, Q3, and 4 of last year have been sustained to date, and we continue to record substantial numbers higher than last year if we compare week by week in the same period. So we have taken this opportunity that COVID has presented by bringing everyone closer and paying much attention to data, and it's yielding results. Where are we with TPT uptake? I would like to share with you that we have equally sustained the TPT uptake. As you can see, 2017, we were only able to initiate or have 42,691 complete. But when you look at 2021, if anything, the number has actually increased 4 times higher as compared to what we did in 2017. So how did we sustain this? We had to look at our approaches, and our best approach that we thought about was to align TPT with ART. And we also brought about the month scripting, and patients were followed up by phone and through some of the community approaches. At the end of the year, we were able to achieve a TPT completion rate of 82%. So this has been our trend of TPT over the past years, 2017 to 2020. And if you compare all these years, 2020 still emerged as our best year. I would like also to qualify that commodity security played a very critical role for us to sustain the intervention, and it enabled us to actually give the month scripting. Without securing the commodities, indeed, we're going to have huge challenges. We are also beginning to see that TPT is proving very useful and is impacting positively on reducing the burden of TB among people living with HIV. As you can see, cases of TB in the blue line are going up, but then also we are seeing that the number of people living with HIV who are developing TB over the years is going down. This, colleagues, is actually corresponding with the period in which we are scaling up TB preventive therapy. So we believe that that decline in TB HIV is from both ART as well as from TPT. So what lessons have we learned? We've learned that weekly data review at all levels of healthcare system is effective in forming the response to TB and HIV intervention. Remote technical support is feasible and sustainable using the virtual platform. Month scripting for TPT is effective in sustaining the TPT interventions amidst pandemics and also other challenging times. Patient education is central in ensuring favorable outcome. for both TB and TPT. I end here, colleagues, and I'm happy to take on questions and to share a little bit more on how Zambia went through the COVID pandemic and has sustained both TB and HIV interventions. I thank you and I wait for questions. Thank you.
Thank you very much for this presentation, Dr. Lungu. It shows actually how much can be done, even in very challenging times. And I can just maybe highlight two things that were particularly impressive for me. Is one, yes, it's really such a game changer when we track the situation, and we could see it in a few countries. And that information, that data helped so much to programs to adapt and actually to do more when COVID was just starting and creating problems for everyone. And then the second, yes, I want to thank you for highlighting the importance of patient education. I can say how important it is, and yet sometimes we think it's not a topic, unfortunately. And yes, if we want TPT to be successful, whether it's the old school isoniazid for 6 months, we need to educate patients. We need to prepare them, and that will change so much in terms of adherence. Once again, thank you very much, Doctor. And I would like to now give floor to our speaker, Dr. Associate Professor Salome Charalambos is the Deputy Chief Scientific Officer at the Aurum Institute and has been involved in TB and HIV implementation research since 1998. Has published areas of TB case finding, TB HIV integration, and HIV program management. She has a specific interest in special populations, including people living with HIV, TB contacts, minors, and prisoners. She also has the Secretariat of the National TB Think Tank that advises the South African government on policy and implementation. She will be presenting on impact of COVID-19 on TB HIV programs, lessons learned, and next steps towards adopting and implementing the updated WHO TB screening guidance in South Africa. Please, Ms. Charlotte, the floor is yours.
Thank you, Timur, and it's a pleasure to be here to present on behalf of South Africa and what we are trying to do in terms of TB case finding. I just want to see if I can change my slides. Okay, so in South Africa, we've been quite happy to be able to have a reduction in TB incidence over the years. Since 2009, we've had a 43% decline in estimated TB incidence, and there's also been a similar decline in mortality with a very sharp decline in 2011 following more implementation of antiretroviral treatment. However, our TB prevalence survey was done in 2018, and we were confirmed we still are one of the highest TB burden countries in the world. We have an estimated prevalence of 852 per 100,000, and there are at least 50 or so in 2018 at least missing cases of TB. And our TB prevalence survey also told us a little bit about TB case finding, and what we found was that unfortunately of the 234 cases that were identified, over 60% would have only been identified on chest x-ray and were asymptomatic, and so would not have been identified on symptom screen. Then the COVID epidemic occurred, and these are the monthly gene expert testing data from the National Institute of Communicable Diseases. And you can see that there is a reduction in the testing numbers. The brown line indicates the forecasted expert test taking into account previous years. And the black line indicates the testing numbers. And there was a 50% reduction in the months April to around October of last year. And this was also shown in the number of gene expert positive tests conducted in the country. So we have a massive gap that has probably exacerbated the number of undiagnosed TB cases in the country. At the same time, we also had some results from a new study, the Targeted Universal Testing Study. This was a cluster randomized trial. And in this trial, what was done was routine testing of all high TB risk individuals in health facilities. That was everybody who was HIV positive, who had history of previous TB, or who had a TB contact. And for this study, all people in these health facilities that were qualified as high TB risk were then tested with expert, and we had a very high yield of expert positivity, 7.8% overall and 5.2% if trace patients were excluded. The study also demonstrated a 17% increase in overall TB yield in the facilities that implemented targeted universal testing versus the standard of care. Further evidence to the need to intensify TB screening comes from the WIP-TB trial. This was a study that followed up people who were HIV infected and on antiretroviral treatment and were placed on different regimens for TB preventive therapy. And at 12 months and at 24 months, all of these participants were tested for TB using TB culture. And you'll see that up until those time points, very few TB cases were identified, but TB cases were identified at those time points. And just to look at that in a little bit more detail, at the 12-month point, there were 30 TB cases identified, and of them, only 4 were symptomatic for TB. And similarly, at the 24-month time point, 5 cases were identified, and none of them were symptomatic for TB. So taking into account the new TB screening guidelines, the massive reduction in TB testing, and the new findings of these studies, the National Department of Health has put together a response plan together with assistance from the TB think tank. And part of this response plan includes a variety of strategies to increase TB testing. One of them is TB self-screening. We're also combining COVID and TB screening at the same time. We are going to be implementing targeted universal testing, increased contact tracing, the introduction of digital chest x-rays at facilities where possible, rolling out TB land testing at facilities, and multi-month dispensing for both TB and TPT. And then I just wanted to acknowledge those who participated in some slide development, and also all of our partners that work with us. Thanks very much.
Thank you very much, Salome. Thank you for your presentation. And I think with this, we are done with our presentations. And now we can move to our next segment of the webinar, which is about questions and answers. So we received quite a lot of questions on our Q&A section, and the section is still open. So please, if you have any questions, feel free to put them there. Right now we have 17 answered questions and 13 questions are still open. And probably I would start with the question that has most thumbs up, which has been there for a while, and I think we need to answer it. And that is a question, apologize if I pronounce the name wrongly, but it's the question from Daleen Karolison. And the question is, do we have some work on TB self-screening for our clients living with HIV? I can see Salome turned on her video, which probably means she wants to answer. Is that right, Salome?
Yes, Timur, I can answer that. I don't think there's formal work out there yet. What I can say is that in South Africa, we used the opportunity that COVID self-screening was happening and revised the tool to include TB self-screening. And at the time that COVID is, when COVID numbers are high and there are a lot of people using the self-screening app, we are finding that there are a lot of people also screening for TB. What we did find, though, was that once when in time periods when the COVID numbers had reduced and there was fewer people using the screening app for COVID, the TB screening did not stay high. So we think that they are unfortunately linked at the moment. We are trying to work to increase marketing around TB screening on its own and to make people aware that they can screen for TB using the app. And we'll see how that goes. You know, what one can find is that it is a tool which is very low in terms of resources, and it actually can identify lots of cases of TB with, you know, if you think about how many resources you would usually need to identify 100 cases of TB, for instance, that our screening app, in a national screening app, was able to do that in a couple of months with very few resources actually being used to do that. So I think there is potential for it, and potential for it in HIV positive populations. Yes.
Thank you very much. And I actually think it's bigger than just for people living with HIV, because we've been educating our communities for ages about the symptoms of TB, so that we all know what are the typical symptoms, and then if you have those symptoms for like quite some time, go to your doctor, go see your TB doctor. And I think it's as relevant as always. Unfortunately, I don't think we can have self-screening using the technologies that we discussed today. Maybe we will live in a world where people will be able to do self X-ray using their phone, like chick, and you know the result. You can see your lungs, or maybe taking like having the CRP tests being more like you know, tiny thing that you put on your finger and you see the results. That would be amazing, but probably we still have some miles to go to get there. So I think we answered that question, but if other speakers want to add, please feel free to write. And then I actually also have a question, if I may. You know, being the DJ is very comfortable and convenient, because I can just ask my question. I have my question. And my question would be to all speakers: what do you think it's going to take us to implement these new guidelines? And is it realistic that we will be able to do that fast and effective? That's my really biggest question, and that's probably bringing us back to some of the challenges highlighted by the speakers earlier, like by Grania or by David. But I would like to know what you think, what we need to do. We have people from different parts of TB community here. What we all need to do to make sure we implement these guidelines. So if we have any volunteers among the speakers, please raise your hand, and I will be happy to hear your answer.
Maybe I could jump in?
Yes, please, Cecily.
So I think from the WHO perspective, we see clearly that we're going to need increase in funding. There's no way around that to really get broader scale screening, not just of people living with HIV, but definitely inclusive of people living with HIV. In fact, you know, I think we all know there was the UN high-level meeting in 2018 where a lot of countries came together and made some very ambitious targets for increasing, in particular, preventive treatment. And actually, we're doing better in this case in terms of people living with HIV, but we still have a long way to go in the broader TB perspective. So in fact, WHO will be issuing a sort of a renewed call for action tomorrow to try and get countries and funders remotivated to try and close this gap in the next 18 months. Beyond that, I think we see the recommendations as sort of the beginning of this conversation in terms of now we need a lot more implementation evidence, implementation research, research from different perspectives on the field that show us how these tools really work in the field and what are really the most effective strategies and algorithms and methods for implementing. And then we need to share that experience across the whole community so that we can all learn from each other's perspectives so that we don't all have to reinvent the wheel. I'll stop there.
Thank you. Thank you very much, Cecily. Grania, please.
Thanks. So, yeah, I mean, I think really to echo a lot of the points that Cecily's made, that funding is a key issue, but then I also sort of think we have an opportunity, you know, for example, the Global Fund's COVID-19 response mechanism actually has a considerable pillar devoted to diagnostic tools. And if you look at what the guidelines have recommended, you know, chest x-ray helps for COVID and TB. So there is a real opportunity to invest in multi-disease diagnostic screening tools. So chest x-ray, looking at the role that TrueNet and Expert that can screen for COVID and for HIV and for TB, how can we package these, build the infrastructure that will help us screen for, diagnose and treat TB. So I think the funding is definitely needed. We do need it, but thankfully we may have a channel immediately available that has a really very fast turnover. So I think that's something for countries to really think about. And I think some of the other points is community engagement. So Timur, you've talked about how we've been educating our community on the signs and symptoms of TB. There's a global education campaign going on about COVID-19, and how can we utilize that so people have an awareness of respiratory health, and that if they have cough and fever, they need to seek health care. And ideally in high burden TB countries, that comes packaged with, we're going to look for COVID and TB. Or if you don't have COVID, we're going to make sure you don't have TB. And is there a reason, I mean, make sure we screen for HIV or other high risk infections. So we've had a massive negative impact from COVID, but I think we also have some opportunities is the wrong word, but, you know, and a window where we can really look to see of how we can reinvigorate our sort of screening, treatment and prevention of TB. And to David's point, there are a lot of these tools are now more expensive. So we do have an advocacy and an access challenge ahead of us, but also we don't need to wait for these tools to become affordable or to become accessible. There's a lot that we can do in the meantime. We can, as Cecilia said, you know, do the operational research, get the models of care established so that as and when these tools do become more available, we have the pathways, we have the evidence so that that scale up can happen a lot quicker. Yeah, so those are my thoughts. Thank you.
Thank you, Grania. And actually your response resonates with the question that we have in our Q&A section from Rose and Sumu, who says that I think the best thing is to integrate TB screening for all COVID-19 suspects. I would say people with suspected COVID-19. Every client who visits OPD should be screened as long as the client to the facility being unwell. From here is where we will be able to filter all suspects and do appropriate referrals. And this is what also the Global Fund is recommending. And this is the opportunity that you, Grania, mentioned in terms of C19RM being available to countries. And that's actually a huge opportunity. And before I give floor to David, maybe I will just mention, you were cautious using the word opportunity, but actually I was amazed to know that the word crisis in Chinese is written by two strokes. One means danger, the second means opportunity. So this is the inspiring part. So David, please, you have your hand up, so please feel free to comment.
Thank you very much. So to speak to you know, how these new screening guidelines can be scaled up and implemented in countries. One critical way to do that is to invest in in-country civil society organizations and community and civil society-led initiatives to build community literacy around TB screening, diagnosis, treatment, the updated algorithms, and to create demand in countries for these new algorithms and these tools, and to support these in-country organizations to engage in advocacy at the local level, to hold their governments accountable and their TB and HIV programs accountable for implementing these new screening guidelines. And like I said in my presentation, access to screening and testing at the highest standard of care is a human right, and governments are obligated to implement WHO recommendations in order to realize the rights to health and the rights to science. And related to community engagement, one example has been the community engagement under the Impact for TB project with the Aurum Institute, funded by Unitaid. And that's one example in which community organizations have been working to build that demand and towards scaling up TB preventive therapy. And also relatedly, community-led monitoring is another key tool to identify gaps in implementation at the community level and to engage members of affected communities in communicating those gaps to country governments and to donors and other organizations to identify where the strategic investments and interventions can be made to fill those gaps in implementing the guidance. And lastly, as we had all mentioned, there's an issue of affordable pricing of new tools. And that has been a challenge for a number of tools. And looking particularly at rapid molecular tests, I understand that many countries are using rapid molecular tests such as GeneXpert more as a test for drug resistance as opposed to an initial TB diagnostic test, which is not how it's recommended. And a lot of that is related to the high price of GeneXpert testing compared to the older test smear microscopy, which is not sufficiently sensitive as an initial TB test. So there remain these questions about how we can achieve lower prices for rapid molecular tests. And I'd like to also just highlight the test and treat model for using rapid molecular tests such as GeneXpert or TrueNat as a screening tool for among people living with HIV. In patients, it's a strong recommendation. Among all people living with HIV, it's a conditional recommendation. And the sensitivity and specificity of rapid molecular tests is very high. And if we can get beyond the barriers of affordability and scale up and implement these tests in that use case of as a TB screening tool among people living with HIV, we could really begin to see some better outcomes in terms of testing and diagnostic yield and linkage to treatment.
Thank you very much, David. I would probably just like to quickly comment what you mentioned in the earlier part of your comment. Myself being a person living with HIV and a TB survivor twice, I have seen what kind of difference it makes when you actually get empowered by knowledge, and that generates demand. So when there is demand, there is more pressure to actually move to certain things. And I can say that this is exactly what TBpeople and other community organizations are really pushing for. And we're here completely united with TAG in terms of, yes, we need to push for more accessibility, affordability of new tools. And the best way this can be done is by empowering community organizations and civil society groups to create demand, to generate demand. And I think that's the way to go. And hopefully that message is well heard, both by the Global Fund and other donors, and also our technical partners, including WHO. We are all together in this fight. So if we want these guidelines, as well as other TB-related guidelines, to be implemented well, we have to be doing this together. We shouldn't be seeing people with TB as patients, people living with HIV as clients. We need to be seeing each other as partners in the fight. We have one common enemy, that's TB. So Salome, I see your hand is up, please.
Thanks, Timur. I just wanted to, sort of also, sort of agree with Cecily and Grania about the funding and the evidence that's required. But at the same time, I also just wanted to make an appeal to us all as the TB and HIV community to be a bit braver than we have been. That with COVID, we have seen that, you can make, policy decisions and then you can take them away again. I think we seem to think that, with TB, for instance, especially that, a guideline is something that we have to put in place and it has to stand forever. And right now, the COVID crisis has led to reduced testing and identification of TB patients throughout the world. And, maybe this is a time to try some of that bravery and put in place some strategies. And if they don't work, then we go back to our evidence and making sure that everything is in place, but at least, try some things that maybe we wouldn't have done in the past. And I think COVID's just shown us that you can do that, and that, if you change it the next month, the next week, I mean, that's what we did with COVID, right? And so just want to appeal to policymakers, especially those trying to implement the guidelines, maybe to be a bit braver than they would have normally have been and see where that takes us. Thanks.
Yeah, thank you very much. Thank you very much. Bravery is, I like bravery. And maybe we have a few minutes. Maybe I would ask Dr. Lungu, who was quite silent during our Q&A session. And there are actually a few questions, Dr. Lungu, addressed to you in the Q&A section. Maybe you would be able to take a few minutes to answer them live rather than type responses, as I see you are doing. Is it okay with you, Dr. Lungu? You're muted.
Thank you very much, Chair, and all those that have brought out the questions on my presentation. I would like to take this opportunity to respond to some of the questions. So I think number one is the question that is looking at, did we really see a reduction in the HIV, in the TB screening among people living with HIV? What we have actually seen as a country over the number of years and also in the era of COVID is that we actually increased our TB screening amid this COVID. So in as much as we tend to month-to-month scripting, the month-to-month scripting was actually adopted for those who are stable patients and also those patients who have very good viral load suppression. And they have got a very good history in terms of their ART care. Those are the people who were transitioned to the month-to-month scripting. It was not almost everyone. So those new in care followed partly the routine schedules. So in essence, we still maintain enhanced TB screening among those people living with HIV. And what we have seen that over the number of years, if we compare the TB screening among people living with HIV, even in 2020, where we had the COVID outbreak, it surpassed the previous years. Our decline in cases of TB among people living with HIV is corresponding with the period in which we are actually scaling up our TPT. If you look at our TPT completion rate or uptake, we have over 70 patients in the last 3 years who have actually accessed TPT. And you do recall that immediately one starts TPT, the effect on suppressing TB starts from day one. So essentially our decline in cases is both from a good ART uptake, good viral load suppression rate. Zambia has attained all the 390s in HIV, and coupled by a very good TPT uptake. So these two, we have a compounded effect from both ART as well as TB. But in terms of TB screening, we have not decreased the number being screened for TB. I think those are one of the major questions. In terms of the adverse effects, yes, we did record some adverse effects due to TPT, but these were very, very few and minor. And one of our observations is that we noted adverse effects in those who had low BMIs, and we attributed that to low albumin and also low nutrition status. And once we started supplementing nutrition in those who have low BMI and being put on TPT, we have actually seen less and lesser adverse effects. And the other issue that we've also emphasized on as a country is that for every patient who we are starting on TPT, we should actually provide B6, that's the pyridoxine, so that we prevent the adverse effects coming from INH, the peripheral neuropathies and the like. So in essence, I think we've mitigated for the adverse effects in that sense. And also we do warn and also educate the patients on the possible side effects attributable or that could arise from TPT. And through this, we've been able to recognize the adverse effects much quickly and address them before they become life-threatening or quite severe. So over time, I think we're seeing lesser and lesser side effects. Zambia is one of the countries that has started implementing 3HP. We are in the 3rd month of 3HP, and others actually are completing. What we have realized actually in the first cohort of patients on 3HP, there's been hardly any side effects to 3HP. That's what we have observed. We've been paying closer eye on adverse effects, but we are seeing lesser and lesser side effects. If at all there's any should be mild, that does not warrant halting the TB preventive therapy. So I think that's in a nutshell what I would like to say. If I've left out any questions, you could remind me. I think those are the questions I received. Thank you.
Yes, thank you very much. Thank you very much, Dr. Lungu, for your response. And I think we could be closing our questions and answers section. So as Kevin just wrote in chat, if you have the questions, you can send them to the email provided there. So please feel free to bother our panelists with your questions. And hopefully the panelists will be happy to respond. So I want to thank all of the speakers for the presentations and for the participation, for providing the answers. I think it was a very informative event. And I also want to thank the audience for being very active. We received so many questions from you. So probably it means that this event was really relevant. So when you leave this webinar, you will be automatically requested to fill out an evaluation survey. So please take a few minutes to complete it. I don't know, maybe it's actually very short. So maybe Laurent or Lina, correct me if I'm wrong. It probably should be very short, but the feedback will be very important because IAS hopes to continue improving the webinars for the future. So once again, thank you for participating in this webinar, which has now come to an end. So the recording of the webinar will be available in the Educational Fund website. And the link is is already in the chat. So thank you very much. And with this, I think we can close. Thank you. And have a wonderful day.
Thank you, Al.
Okay, everybody.